Yeah. Hello, everybody. Good evening. Uh, Today, I wanted to show you around 3 to 4 cases based on the time. So usually, most of the times, it will be like a more of a descriptive type of a case, and other 2 or 3 will be straightforward, straight cases, short cases. So yeah, we have one knee joint, one elbow, and one is an hand, and other is an ankle today. So there are 4 cases. We'll start with the ankle joint. Just give me a minute. I think it's not opening for me. Yeah. Just give me a second. I'm able to share the screen. Yeah, now I'm able to do it. Yeah. Is my screen visible now? Yeah. So let us start this case. So if you see, these are the images. I'll just go scroll through and go through the images. So this is the right ankle. How I'm saying it is the right ankle. Usually, if his patient is positioned properly, by seeing the images itself, we can say whether it is a right or left ankle, or it is a right knee or left knee. So if my fibula is on to the right side, this is a fibula which is on the right side, I'll go and take it as a right ankle. What is a right ankle actually? So if the fibula is on the right side, then it is right ankle. So yeah. So what we are seeing here, I'll just scroll through the images. Please go through the images. They're done an ankle because the patient is complaining of pain in the lateral aspect of ankle and foot. But my technician and the clinician has advised only ankle for the patient and not foot. These are the T1 images, coronal. Yeah. So I'm showing the case. So if you see here, the anterior talofibular ligament is intact. Okay, the posterior talofibular ligament is intact. And I'm going down. If you see, this is the calcaneofibular ligament that is also intact. So the patient is having pain. And if you see, there is a marrow edema in the base of fifth metatarsal. If you see on PDFS images, there is significant amount of marrow edema. There are adjacent soft tissues and muscle plane is also showing inflammation and hyperintensity signal on PDFS images. So Then what could be the cause of this? The patient had so patient had injury of the ankle. So there was an inversion injury. So inversion injury. So usually we suspect anterior talifibral ligament tear, and the clinician also suspected the same. But I don't think so. The clinician has examined the patient, but he asked for an MRI of the ankle joint. So what is happening here? If you see on PDFS itself, I can see some amount of fracture here in the base of fifth metatarsal. So I'm going to the T1. Yeah, this is the study images. On the study images also, you can see significant of marrow edema, significant of marrow edema. So these are the T2 weighted images. If you see T2 weighted images, see, you can see a clear line of fracture in the base of fifth metatarsal. So where exactly this fracture is happening and what is the cause of fracture? The cause of fracture here, if you see, these are the peroneal tendons. If you see, there is a peroneus longus and brevis tendons, right? So this is our longest tendon, and this is the brevis tendon. So this brevis tendon, if I see, I really see if this is the brevis tendon attachment. Okay, so there is a avulsion fracture of base of fifth metatarsal secondary to avulsion of pull of this peroneus brevis tendon. So it's not so clear here. So what we can see, you can see on the T2 weighted image here. If I see the T2 weighted image, if you see this tendon is going and inserting onto the base of fifth metatarsal, because of its pull, there is fracture in the base of fifth metatarsal. So avulsion injury of fifth metatarsal base secondary to peroneus brevis avulsion. So this is peroneus brevis avulsion fracture. So if you see this, this is the peroneus longus tendon. So what happens to the peroneus longus tendon? Where exactly peroneus longus tendon inserts? Peroneus longus tendon, if you say it go behind this, all these tarsal bones, the distal row of tarsal bones, and gets its attachment. If you see, you just trace it. You can trace it. Yeah. So if you can trace it, it will go and insert onto the base of first metatarsal and cuboid bone. So cuneiform bone, medial cuneiform bone. So that is the, yeah, this is the medial cuneiform. So if you see here laterally, we have this cuboid, right? So beneath the cuboid, this peroneus longus tendon goes and inserts onto the base of first metatarsal and medial cuneiform bone. So that helps in maintaining the arch of the foot and dynamics of the foot. So So this is the case of pain in the lateral aspect of the foot and ankle post inversion injury. We see a fracture in the base of metatarsal at the insertion of peroneus brevis. So this is the peroneus brevis avulsion fracture. This is the first case. Yeah. Yes. So many people. Some people mentioned stress Jones fracture, stress fracture. It's more of a avulsion fracture here. Yeah. Thank you. So this is the first case I wanted to show. So next case, what I wanted to show you is elbow joint. So it's more of not an elbow joint, more of an arm and elbow. So forearm, more of a forearm case. So what happened here? The patient had a wrist drop, had no significant history of trauma or injury. Periodically, over a period of time, the patient developed uh, wrist drop. So if you see, I'm scrolling through the images. Okay, you can see the images before discussion. Okay, then if these are the T2 weighted images, what I'm showing you. Okay, then this is the stir axial. Anything we are noticing, and what is happening here? Please comment. Yeah, very good. So what is happening? What I'm able to see in this section of images? So the extensor compartment of the forearm, the muscles show increased signal intensity on star images. You see, on if I'm going on to the T2 weighted images also, there is increased signal intensity. These muscles are showing early changes of fatty replacement. So, and also, this is because this distribution is the posterior intraosseous nerve distribution, and if you see there is a ganglion sitting in the region of supinator. This is a supinator muscle, neck of the radius. This is the neck of radius. So, what is this muscle which is going and inserting onto the radial tuberosity? You see, that's the function of the muscle is also same as of supinator. So that is biceps. This is a long biceps tendon. This is a muscle. I'm going down. This is a long biceps. So this is a biceps tendon. Biceps tendon inserting onto the radial tuberosity. So biceps has two functions. One is flexion, other is supination. So the supinator is the other muscle. So if you see here, that helps in supination. So this supinator muscle has a ganglion cyst here. See, if you see, this is the ganglion cyst here, extending anteriorly into the intermuscular plane, which is multiloculated, causing compression over the posterior interosseous nerve. Posterior interosseous nerve is a branch of radial nerve. If you see, I wanted to show you the radial nerve. Yeah, can see this. This is the radial nerve here. Here it will give a branch so that go inside the supinator, pierces the posterior interosseous nerve is the nerve which pierces the supinator and goes into the posterior aspect of the forearm. So it should come here like this. So along, if you can trace this in this track, it will follow. If you see, so this is the posterior interosseous nerve. It should go. If you see here, this is the nerve again. So because of this ganglion cyst, there is compression over the posterior interosseous nerve, causing mild amount of fatty atrophy and wrist drop in this case. Yeah. So, yeah, this is another straightforward case which I wanted to show you. This is the second thing. And next, if we go the third case, it's also a case of avulsion. So, what avulsion it is, you have to tell me. I'm showing you the axial PDFS images. Poster, PDFS, yeah. Axial PDFS images. I'll show you coronal, sorry, Sag, PD. Here is our pointer for diagnosis. Any comment? Why profundus? Because it is deep. Why is it profundus? Because it is posterior to the superficialis. Here we see something anterior and this is posterior because of so. Yeah, it is superficialis. Flexor distorum superficialis. Why? Flexor distorum profundus tendon, if you see here. Yeah. Yeah, inserting onto the rock. Yeah. Distal phalanx. Flexor distorum profundus tendon inserts onto the base of uh, distal phalanx. Okay. And our flexor distorum superficialis tendon goes and inserts onto the base of middle phalanx. Yeah, middle phalanx. So here is the insertion actually. Okay. So this tendon got torn and retracted and seen at the level of proximal 1/3 of shaft of proximal phalanx. So there is significant amount of retraction here. So there is a tear here. If you see here, this is the if you see this is the insertion actually. I have to zoom. I'll just zoom and show. This is the insertion. So at the base or proximal aspect of middle phalanx, the flexor digitorum superficialis tendon get inserted. So here it got torn, and this is the retracted end. So so we need to mention about the distance, how much it is retracted from this stump, from the level of insertion, so that will help the orthopedician in planning about the surgery, whether that amount of tendon, whether he can pull it and attach it there, or he need to do a graft, or graft. So that is the other thing. And one more thing is, most of the times, in this case it is not done, but we need to do a CT screening or an X-ray screening at least to look for any chip, a bony chip attached to the distal stump. If there is a bony stump attached to the distal stump, it is very much easy for an orthopedician to fix it, because bone to bone healing is very good. So if they can directly bring that back into the location. If it is an avulsion, they can bring back to that location, and fix it, so that the bone to bone healing will be usually very good, and then recovery will be very good in case we have a bony chip attached to the distal stump of the avulsion. Yeah. So this is my another straightforward case. I'm showing all the images. So you can see this is a coronal T1 weighted image, PDFS image. T1 stir. So T1 images. Yeah. So this is the fat sat, T1 fat sat. Let's see. You can see this retracted tendon is wavy. And also showing fluid along its tendon sheath. So this is another case. And yeah, if you can see, I wanted to show you this image. So here we can see. This is the flexor digitorum superficialis. This is flexor digitorum profundus. Flexor digitorum superficialis splits into two sleeves and get inserted onto the mid or proximal aspect of the second phalanx, middle phalanx. And this is the flexor digitorum profundus onto the base of distal phalanx. You can see this insertion. So this is how the insertion of the flexor tendon happens. Okay. Then I want to show you the another case here. The knee joint. I'll just scroll through the images. Most of you know the diagnosis. Just say me what it is. These are the two T2 weighted images. This is coronal PDFS image. There'll be associated injuries also, but we want to have what exactly is the diagnosis here. What is happening? So I'll go through the findings. Okay. There is mild amount of knee joint effusion with the fluid extending into suprapatellar bursa. There is mild knee joint effusion with the fluid extending into suprapatellar bursa. There is grade 1 sprain tibial attachment of anterior cruciate ligament. Okay. Grade 2 horizontal tear with the posterior horn of the medial meniscus. Okay, these are all there. And we are seeing some amount of marrow edema in the patella. So what is happening here? Yeah. So if we are seeing there's an inferior medial aspect of the patella, there is fracture and marrow edema. So, okay, what is the attachment here? What we are seeing here, which got torn at this point, avulsion. That is you can see here, this is the medial patellofemoral ligament. So there is high grade tear of medial patellofemoral ligament. And if you see, this is the lateral patellofemoral ligament, which is good. And if you see, this is wavy. So there is high grade tear of medial patellofemoral ligament, marrow edema, fracture. And then there is also marrow edema with subchondral fractures noted in the lateral femoral condyle, anterolateral aspect of the lateral femoral condyle. So what happened here? There was a lateral patella dislocation happened. It was a transient dislocation because it came back again sitting into its normal place. So patella usually tends to dislocate laterally. So patella dislocates laterally like this. So there is lateral patellar dislocation, because of which there is a pull avulsion of the medial patellofemoral ligament. And also, as it is going laterally, this surface of the patella, that is the medial facet and midpole, get rubbed against this lateral femoral condyle, causing this bruise, bone bruise. So this is a case of lateral transient patellar dislocation with high-grade tear of medial patellofemoral ligament. Okay, so what to report in a case of this patellar dislocation? What are all the things we need to look at? So one thing to start with, I look at is whether there is any patella alta, patella baja. So how do I do it? I do an insal-Salvetti ratio. What is insal-Salvetti ratio here? If I take this patella, this is the measurement of the length of the patella, this 4.1, and I take length of the patellar tendon. If it is almost 4.4. So what I do, length of this patellar tendon by length of patella. So it is 41 divided by 44. So it is around 0.93. So that is there is no patella alta or baja here. So usually if it is less than 0.8, it is baja. It is more, if it is more than 1.2, it is alta. So there is no patella alta. Yeah. So this is the one thing what we need to do. One thing is measurement of taking insal salvetti ratio. Patella alta is there or not, patella baja is there or not, or whether it is a normal. Here it is a normal thing. This is one measurement which we need to give. And second thing, what we need to do here is we need to measure the sulcal depth. So if you see, this is a trochlear sulcus. I am drawing a line across and just measuring the sulcal depth. So it's almost 3 mm. So recent studies say 3 or more than 3 is the normal sulcal depth. Previously it was 4 mm, but now in recent studies, even 3 or more than 3 is a good amount of sulcal depth. So if I draw a line, if I'm not getting if I'm drawing a line across this trochlea here from the anterior prominence of this trochlea and taking the measurement, better to take it on a TV two-weighted images so that we can skip this cartilage and do it. So this is the sulcal depth. So this is one thing. And next comes is the lateral trochlear inclination. I'll show you. Yeah. You can see. So lateral trochlear, these are the measurements what we need to give. Measure things like lateral trochlear inclination, whether usually it is more than 11 degrees. Median to lateral facet ratio, insal salvetti ratio, TTG distance. So how is my lateral trochlear inclination here? So I need to have a baseline. My baseline is this. So I'll bring it up and put it here. Okay. And I take the measurement of the lateral trochlea angle. So I take an angle tool here I'll put it 1 here, 2 here, 3 here. So almost the lateral trochlear inclination is around 20 degrees. This is good amount of this thing, which is more than 11 degrees, which is normal. So then we need to take the lateral to medial facet ratio. So lateral to medial facet ratio, or how do you take a lateral to medial facet ratio? It is again the same medial. Take the length tool. Yeah. So you see, and this. So if it is almost like 50%, more than 50%. By seeing yourself, you can say that is 13.8 and 12.2. So it's almost 13 divided by 22. Almost it is 59 degrees, 60 degrees. So more than 40% is normal. So this is one more measurement we need to give. That is lateral to medial to lateral facet ratio. So medial facet to lateral facet ratio, usually it should be more than 40. So sulcal depth, medial to lateral facet ratio, then insult salvati ratio. These are the three things we have done. And other than this, what we need to do, we need to know whether the patella tracking is correct or not. Whether uh, so to know what we need to do is we need to measure the TT-TG distance. What is TT and what is TG? TT is tibial tuberosity. This is tibial tuberosity. So this is sitting here, right? And one more, TG is the trochlear groove. My trochlear groove is sitting here. This is the trochlear groove. Okay, where is that? Yeah, trochlear. So trochlear groove is sitting here. So visually, if you ask me, there is mild amount of trochlear dysplasia here. You see, it is almost not like so concave. It is a little bit flat. But when if we can measure it on a T2 weighted images or a T1 weighted image, it is always good to have the sulcal depth and everything. So and we are looking at TT-TG distance. Okay, so TT-TG is tibial tuberosity to trochlear groove. How do I measure? So I need to measure the distance between that. So first I need to have a baseline. That is a baseline posteriorly here. And I'm going to draw a line perpendicular to this in the mid point of the trochlea. So this is my line here. So what I need to do, I need to select this line. This is a baseline, right? So I need to select this and copy, Control Z or Command Z on a Mac. Go down to the location where we have the tibial tuberosity. This is the tibial tuberosity here. I'll paste here. Control V or Command V. Then again, I will take this, which is the trochlea. This is the line drawn perpendicularly at the midpoint of the trochlea. So trochlear groove, I'm bringing it down till this level. So I'm pasting it here, Control V. So I got this. I'll copy it once more, Control C and Control V. I got it one more, this thing. I'll put it exactly in the midpoint of the patellar tuberosity. If I'm measuring the distance between these two, then that is the TT-TG distance. If you see this is my TT-TG distance. So usually TT-TG distance we measure mostly on the CT films. MR we can do, but there will be a 2 to 3 mm. We should take it at least 2 to 3 mm less than lesser value of the CT value is an abnormal in an MRI. Like if in a CT, if I say that 15 up to 15 is normal, 15 to 20 is borderline, more than 20 is abnormal. So TTG distance. So if on MRI, it should be like my 12 to 13 itself is my cutoff. So TTG distance of up to 10 to 8 to 12 or 13 on an MRI is normal. 13 here is a borderline. So if there is more distance between this trochlear groove, if you see, and the patellar tibial tuberosity, the patellar tracking will be abnormal. So there is every chance that the patella can dislocate. So what are the chances of patellar dislocation in this case? Again, is like there is more increased risk of dislocation here, because already this medial stabilizers, stabilizing part of the joint, that is medial patellofemoral tendon, ligament got torn here. Okay, and the TGT so because this medial stabilizing part is not there, there's every chance that patella can dislocate again. So this is one thing. And TTTG distance, as we see this initially, what we measure, this is a borderline in this case. So how to measure TTTG distance? Shall I show you again? I'll show you again. I'll delete all these things. I'll redo it. Okay. Even we can do it on Radiant and also on Osrix or Horus, anything. So first we need to draw a baseline posteriorly here, posterior to the condyles, then one line perpendicular to the midpoint, or one line perpendicular to this line passing through the trochlear groove. Then copy this line which we have drawn with the Control C or Command C. Then go to the level of tibial tuberosity. This is the level of tibial tuberosity. Paste it. Go up. Get this line which we have drawn for the trochlear groove. Go down to the tibial tuberosity. Paste it. Again paste it, so that we'll get a second line. Just drag it and put it at the center of the tibial tuberosity, and just measure the distance between these two perpendicular lines. That is our TTTG distance. Okay. So just wanted to show you, this is a case of patellar, transient patellar dislocation with patellofemoral. Yeah. So, but with the medial patellofemoral ligament tear, and what are the measurements we need to do in a case of transient patellar dislocation. That's it. And almost 4 cases, and this is the last case which has some description, so I kept it for the last. Thank you. Thank you very much. Thank you for everybody.